Thank you everybody for joining in. I already can see there are nearly 60 people here. This is extremely encouraging. What we will do is essentially basically take you through the physiological basis of one lung ventilation, and then uh, possibly then take a break, maybe look at questions, and finally uh, go through the management bit of one lung anesthesia. So, what you see is lung volumes and gas exchange during anesthesia. What we will try and do is take you finally through gas exchange through anesthesia. Okay, so what general anesthesia does to the physiology of breathing, if you want to see, it affects both the static as well as the dynamic behaviors. By the static, we mean the pressure volume relationship, and as well as the dynamic behaviors like the pressure flow behaviors. So that's what general anesthesia does to the physiology of breathing. Uh, Coming to the main thing that anesthesia does is the moment you anesthetized a person who's already supine, the FRC or the functional residual capacity reduces by 15 to 20% of the awake value. Remember, the same change happens the moment a person is erect and then becomes recumbent. The FRC goes down by 15 to 20%. And this recumbent patient, moment you administered a general anesthetic, it reduces by another 15 to 20%. So this is one of the things that GA does, general anesthesia does to the FRC, and especially to somebody obese, because this is related to age and body habitus. Especially in the morbid habits, this decrease can be up to 50% of the pre-anesthetic values. And so this becomes a real bothersome thing. So what general anesthesia does to the physiology of breathing, this is one of them. So what is the reduced FRC's effect on the airway? So at the high lung volumes, the effect is large, and the low lung volume, it is long, and it can change the caliber of the airway. So, and this is in one way a passive change in the airway resistance, which is independent of airway constriction. So FRC can also affect the the dynamic behavior. The general anesthesia, by the reduction in FRC, can change the dynamic behavior of breathing as well. Okay, so when does this happen? It starts in nearly instantaneously. Reduction occurs within a minute after induction. Fortunately, it does not progress with time unless something else also is happening, or you're doing something else by which the FRC can come down. And it is not, it has been seen by most studies, that not affected by further addition of muscle relaxants. So that is why if you want to reduce this, it has to happen quite early. Okay. So why does the FRC decrease under a general anesthetic? If you look at the main, it's a complex mechanism and it's not totally understood. And the possible mechanisms through which it can happen is through atelectasis, increased expiratory muscle activity, which is coming up, emptying the thoracic cavity. The trapping of gas in the distal airways is closing, so trapping, so FRC goes down. Cephalate displacement of the diaphragm during general anesthesia, decreased outward chest recoil. Remember, there are two recoils: the thoracic cage. There is an outward chest recoil, where there is an inward recoil of the lung, and there is a decreased outward chest recoil, where there is an increased inward recoil of the lung, which is why again you can have decreased FRC. And there could be any reason wherein there is an increased thoracic blood volume. Classically, when you put them to sleep, the thing that is in the limbs are coming into the thorax, and that is how the thoracic blood volume can go down. So those are the reasons by which the FRC could decrease. Uh, is the type of anesthesia, does it influence the reduction of the functional residual capacity? Yes, it is more dramatic and more pronounced with inhalation anesthetics than with intravenous. but it can happen with intravenous, but it is shown to be lower than with inhalation. And it essentially possibly is because the halogenated inhalation agents decreases the tonicity of the diaphragm and the intercostal muscles, which is why it is possibly higher with that. So that little let's now move out from FRC and look at the mechanics of breathing. So with general anesthesia, what happens to the distribution of ventilation? Essentially, what we will try and do is look at what is happening to ventilation and look at the other part, which is look what is happening to the flow or the vascular component of the physiology of breathing. So let us look first at ventilation. Ventilation per se is not uniform throughout the lung. And why is it not so? Because of this effect of gravity and the shape of this thorax. And because of that, there is a vertical gradient of the pleural pressures. And what do I mean by that? Is that the pleural pressures in the upper or the non-dependent areas is more subatmospheric, that is, it is more negative than what it is in the lower dependent portions. I think all of you know this. And this ultimately leads to that the non-dependent portions are more inflated. This is a classical diagram which explains how this is happening and which kind of tells you that the possibility the lung is a little globular in structure. Uh, Through the physiology of the breathing, you'll figure out that the pressure in the airway tract is the same throughout, while the pleural pressures changes, and the gradient between the pressure in the airway, or maybe you can say the pressure in the alveoli minus the pressure in the pleura, determines the distension of the alveoli. So if you look at what is the uh, alveolar gradient, this is what is possibly the one that is causing the distension, and this is what is how it is arrived at. How much do the gradient change? It changes by around 0.4 centimeter of water per centimeter of the lung. So if you look at a lung which is around 30 centimeter in height in the erect posture, the gradient changes by around 7.5 centimeter, which is the pressure difference between the apex to the base. In the supine position, the height of lung reduces by 1/3. So this effect is diminished, but it still exists. And this is important to realize because when we'll talk about one lung ventilation and one lung anesthesia. So how does this pleural pressure gradients actually make a difference? And we talked about this transpulmonary pressure and how does this transpulmonary pressure or a change in transpulmonary pressure it acts as a function to distend the alveoli. Say, because of this gradient, and because whether they are supine, so whether whatever be the height, so there will be a gradient. For a given transpulmonary pressure during breath, the changes in volume is more in the dependent areas. So you can make out from this graph over here. So if the alveoli is lying over here and there is a change in the transpulmonary gradient, the distending pressure, the change that you obtain will be more than if you are trying to see a change over here. So because of the sigmoid shaped pressure volume curve, the dependent areas are in the steeper part of the slope and therefore it produces a greater change. Unlike in this part of the slope where it is flatter, that there is a lower regional compliance, and so the larger non-dependent areas are in the lower part of the regional compliance, and which is why the less steep portion of the curve. And if you look at this graph, this explains it even better. If you find that, as we talked about, the non-dependent areas are lying in the steep part of the curve, and so the regional compliance is low here. So for a given transpulmonary pressure change, the change in the volume will be much less than in the dependent areas where the alveoli reside. You'll find they're in the steeper part of the curve, and for a given change in the transpulmonary pressure, the change will be much, much more. So this is trying to understand how the pleural pressures influence the distension of the alveoli. So you find that there is this alteration of ventilation based upon where the alveoli are positioned in in the given lung complex, and that is how the difference between the kind of changes in the volumes in the dependent areas to the non-dependent areas. Is there any alteration of perfusion as well? I think everybody kind of understand this, that due to the gravitational effects, the dependent or the basal areas are better perfused, while in an awake spontaneously breathing patients, the bases are better ventilated, and this leads to a good matching of ventilation and perfusion. And I think this is again one of the things that everybody goes through as to what is happening with the changes from the top to the bottom of the ribs, and what is happening to ventilation and what is happening to perfusion. You can find that as you go down, the ventilation also increases, the perfusion also increases, but the rate of change of the perfusion is higher than the rate of change in ventilation, which is when you plot the VQ ratio, you find that it is going down as you are progressively going down the ribs. So which essentially leads to this kind of a figure that you get, that the if you look at from the apices and you go down, and if you look at what is happening to ventilation, it is going up. What is happening to perfusion, it is also going up, but the rate of change of perfusion is more than the rate of change of ventilation. And if you see from top as you go down, the VQ ratio is going down, and it is reaching the lowest at the basis bottom of the lung. And at the bottom of the lung, you'll find, if you're looking at gas exchange, the PO2 is going down, but the PCO2 is also but going up. So this alteration in the VQ ratio leads to a phenomena whereby then you say, if you look at just only the basis, the bottom of the lungs or the dependent areas of the lungs are more hypoxic and more hypercarpic. Why does it happen? This is when you understand the carbon dioxide dissociation curve and the oxygen dissociation curve. The blood, when it is passing through an underventilated alveoli, tends to retain its carbon dioxide and does not take up enough oxygen. But while it is passing through an overventilated alveoli, which is rich in oxygen, it tends to give off an excessive amount of carbon dioxide, which is essentially because the slope of this carbon dioxide dissociation curve is linear, but it cannot take up a proportionately increased amount of oxygen, because if you remember, the oxygen dissociation curve is sigmoid shaped, and over there it might be at the flatness, and that is why it is not able to take up an proportionately increased amount of oxygen, which leads to a phenomena that a lung which has uneven ventilation perfusion relationship can better eliminate carbon dioxide than it can take up oxygen. So if you then correlate this, you'll find that the gradient between the alveolar carbon dioxide tension to the arterial carbon dioxide tensions are smaller, because carbon dioxide elimination is more efficient, while since oxygen uptake is less efficient, there is a higher gradient. So the alveoli might be rich with oxygen, but the arterial oxygen tensions are lower, and therefore this gradient between the alveolar to the arterial oxygen pressures are large. So this is why it happens. You will figure out that this also has relevance when we look at what is happening in one lung anesthesia. Now, this is what will happen anyway. Okay, dependent lung, non-dependent lung, changes in ventilation, changes in perfusion. Does this change with the introduction of anesthesia into it? Yes, it does. In the supine, anesthetized, and a paralyzed person, the ventilation or the distribution of gas becomes more uniform from the top to bottom. It is not absolutely uniform, but tends to become a little more uniform. Whereas anesthetics will cause some reduction in the fall of the pulmonary arterial pressure, which impedes perfusion of the non-dependent lung regions. And add to this, you have this increased alveolar pressures during mechanical ventilation because of paralysis where the upper things, and this diminishes the flow to the non-dependent areas further. So which leads to, like, this is what happens in the awake state, as I think we discussed from the top to bottom, that the ventilation is also increasing, perfusion is also increasing, but the rate of change of perfusion is more. What is happening in paralyzed patient is this is what is happening in the paralyzed patient. So the ventilation is becoming more uniform, the perfusion remains the same. This leads to a mismatch of ventilation and perfusion with anesthesia. So the dependent lung becomes well perfused and poorly ventilated, whereas the non-dependent lungs might have similar ventilation but definitely has less perfusion. So this is with advent of anesthetics, which is contrast to what is happening without the anesthesia. Now, if you look at the pulmonary circulation, we have gone through the pulmonary flows, and now coming to the pulmonary circulation, the pulmonary circulation in some way resembles the systemic circulation. It also has a pump, in this case the right ventricle. It has a distributing system of the pulmonary arteries and arterioles, and a collecting system of the pulmonary veins, with the exchange system as capillaries. This bit is nearly the same as you would expect in a systemic circulation, but there is cross differences with the systemic circulations. It is a relatively low pressure system with very compliant vessels, and the low pressure is despite a higher blood flow than the other organs. Remember, the entire pulmonary circuit receives the entire cardiac output, and this pulmonary circuit, this is where it is hugely different, has the ability to accommodate 3 to 4 fold increase in cardiac output with minimal change in the pulmonary arterial pressure. Very, very important during exercise or during increased cardiac output. And this essentially possibly is because of the thinner pulmonary vessels, which contain lesser smooth muscles and therefore are more distensible. This diagram, I think most of you would have already seen it, as to how therefore this distribution of pulmonary blood flow affects the pulmonary vascular resistance. And critical to understanding this is to understand that there are two types of vessels, the alveolar vessels and the extraalveolar vessels. And the alveolar vessels and the extraalveolar vessels kind of behave differently with the spectrum of inflation. So what happens during maximal ventilation or maximal intake, that is when it is going towards total lung capacity, and what happens during when the lung is shrinked and it is nearly towards its residual volume? This graph explains it. So what happens is the extraalveolar vessels, with the lung expansion, the resistance diminishes. And why does it diminish? Because the diameter of the extraalveolar vessels, you can see here, increases due to the outward radial traction of the subatmospheric pleural pressure. So at the total lung capacity, you'll find the resistance is the lowest at the extraalveolar vessels. But what happens to the alveolar vessels? The alveolar vessels gets compressed and a reduction in caliber at when it is assuming the towards the total lung capacity, and there is a reduction, and therefore the resistance of the alveolar vessels is the highest. It will be just the opposite when it is going towards residual volume. You will find the alveolar vessels are more stretched while the extra alveolar vessels are getting constricted, and therefore if these are the extra alveolar vessels, the resistance how it is changing with change in inflation, and when you merge these two graphs together, you get this bold line, which is the pulmonary total pulmonary vascular resistance, and therefore the total pulmonary vascular resistance is the lowest at FRC, and it will increase as you go towards the extremes, that is towards total lung capacity, or you go towards the residual volume. So understanding this leads to understanding the regional blood flow stratification. And again, just like ventilation was imperfect and unequal, even the blood flow is unequal. It decreases linearly from bottom to top. And this is because, one, definitely hydrostatic pressure, with differences in the vessels arising with the effect of gravity, but also the distensibility of the vessels, the transmural distending pressure, the vertical gradient of pressure in a low pressure system. So this also contributes. I think this is again a diagram which most of you would have seen, how the regional blood flow is different from at the non-dependent areas to the dependent areas, and what are the factors. And this was initially described by West, and this is, remember, only about pulmonary blood or the blood flow. It is nothing to do with ventilation. This is to do with the vascular supply. And essentially, it looks at pressures in the alveoli, pressures in the pulmonary artery, and pressures in the pulmonary veins. At the top, the pressures in the alveoli is highest. It is more than the pressure in the pulmonary artery, and there is hardly any flow, or the dependence of the flow will depend upon how much, if the pulmonary artery pressure actually exceeds the alveolar pressures. Then you have the second area, or the waterfall zone, where the pulmonary artery pressure is higher than the pressure in the alveoli, and this is where it acts as a resistor, and this is where you really want it to be, where the only determining factor is the pressure in the pulmonary artery and the difference of the pressure between the pulmonary artery and the pulmonary vein, and that is how the flow through the vessels will happen. And if there has been described after the initial three zones is a zone wherein there is an extraneous factor which is outside the alveoli, and the interstitial, if there is interstitial fluids, or the pressure in the interstitial fluid, which can play a part if it is obviously more than the venous pressure, but if it has to be obviously less than the arterial pressure, and the flow therefore will depend upon the difference between the alveolar pulmonary artery pressure and the pressure in the interstitium. So this is again to understand how the regional blood flow is different depending upon the dependent and the non-dependent areas. Remember, this is just a conceptual framework of the pulmonary blood flow distribution and can change with varying degrees of inflation. And this classic model of West is pronounced at total lung capacity. Coming therefore to pulmonary vascular resistance. And what is pulmonary vascular resistance? It is essentially it is determined by, I think this is, everybody understands this, is the difference between the inflow pressure, that is the pressure in the pulmonary outflow, and the outflow pressure, which is the left atrial pressure, and its relationship with the total pulmonary blood flow, which is cardiac output. So essentially you get down to PPA minus PLA divided by CO, and you will put, that's how the algorithm works to determine the pulmonary vascular resistance. So in systemic, when you're looking at systemic vascular resistance, you know that this rise in SVR is essentially due to the constriction of the vessels. However, in this pulmonary circuit, it could just not be only constriction of the pulmonary vessels, It could be influenced by things like lung inflation, the collapsibility of vessels, and other hydrostatic forces. So, what are the unique characteristics of the pulmonary circulation, and how does this manage? We remember we talked about it, that it is different from systemic circulation, that even if there is a 3 to 4 times change in the cardiac output or the amount of pulmonary blood flow, the pulmonary pressures do not go up, and therefore the PVR does not go up. So it is essentially because of the capacity to decrease the pulmonary vascular resistance as pressure within the arterial or the venous system rises. And this happens by two phenomena. One is recruitment, which is opening of the otherwise closed capillary, and possibly the primary mechanism. So you had capillaries which are there, which were not part of that circuit, but because of more flow, it is opening up, and so it gives more area, and the PVR does not go. The other phenomenon that can out is distension, whereas there is an increased diameter of the open vessels. So the diameter this is the distensibility, and this is because of possibly, as we have discussed, less amount of smooth muscles. So it has the ability to distend more, and therefore the resistance does not increase much. Lung volumes do influence the distension of vessels, and this is one of the first things that we discussed during the changes in FRC and also when we were discussing about the changes between the total lung capacity and the residual volume. The extra alveolar vessels are more open at higher lung volumes, and so that decreases the ultimately the PVR, and the alveolar at lower lung volumes remain stretched and has a part in decreasing the total pulmonary vascular resistance. So this is how the pulmonary circuit manages the extra amount of flow. And the other thing that we kind of understand is hypoxic pulmonary vasoconstriction. So in the systemic circulation, what does hypoxia produce? It produces vasodilation, because that will aid in oxygen delivery to that tissue. So if you have a hypoxic area, there will be vasodilation to improve the oxygen delivery. In the pulmonary circulation, the reaction to hypoxia is vasoconstriction. This diverts flow away from the hypoxic alveoli, and it matches the ventilation perfusion. So this ultimately will possibly minimize arterial hypoxemia. So this is in why you want to have, or why there is hypoxic or HPV in the pulmonary circuit. Very critical to understanding HPV is that this depends on the size of the area that is hypoxic. If you have a small size of area that is hypoxic, then HPV works. So there is a diversion of flow from that area to another area, and there is no change in the ultimately in the pulmonary arterial pressure. But if a large area is hypoxic, or there is a diffuse hypoxia or generalized hypoxia in the circuit, the flow therefore cannot be diverted because all the areas are hypoxic. But this hypoxia would lead to then vasoconstriction. That is the phenomena that is happening. There is a rise in PA pressure, happens without getting the benefit of hypoxic pulmonary vasoconstriction. So is it beneficial? Yes, it is beneficial, but it remains beneficial as long as the area is small and regional. If it is global, it is not beneficial, and it will raise this phenomena also goes on to increase the rise in the PA pressure. And where does it work? It works at the small muscular vessels which are very close to the alveoli. Remember, hypoxemia is happening at the alveolar levels. So this is happening at the precapillary arterioles of smaller size, between 30 to 50 micrometers. And the most important stimulus is the alveolar oxygen. And if it is low, it stimulates hypoxic pulmonary vasoconstriction. It is maximal at a PaO2 of 30 millimeter of mercury. The other factor that can play a part is the mixed venous oxygen pressure, and which can play a part when the alveolar oxygen pressures are very, very low and still not sufficient for the physiology to work better. and also happens in atelectatic lungs where it is not able to reach. So the mixed venous pressure, if it goes down, it can lead to hypoxic pulmonary vasoconstriction. Does anesthesia influence hypoxic pulmonary vasoconstriction? Yes, it does. Halogenated inhalation agents have been shown to inhibit HPV in a dose-related manner. How much it has clinical significance is a different matter of conjecture altogether, because this entire process of HPV could be obscured by the hemodynamic effects that the halogenated inhalation agents creates, and there are other things which influences, chief amongst them being the lung mechanics, because it can play a huge and a more significant role in the impaired gas exchange during general anesthesia. So if you find that you're giving an inhalation agent and there is an impairment of gas exchange, it may not be because the inhalation agent is causing inhibition of HPV and therefore causing impaired gas exchange. More likely is that the lung mechanics are playing a part in causing this impaired gas exchange. Having gone through, I think, the more boring part of the respiration, the physiology of breathing, let us zone in at what actually happens when you give one lung ventilation, the position you need to have a patient when the person is undergoing thoracotomy. So let us look at the lateral decubitus position and how it is affecting the distribution of perfusion and ventilation. Mind you, these are the two things that will play a part in how it is changing and how therefore it then has implication in clinical management. We'll break it up, and this is nothing that I have done. This is classically, which has been described by Pete Slinger, Benumov, and it looks into first, find out what happens with the lateral decubitus position, changes in perfusion, changes in ventilation when the person is awake with a closed chest, then anesthetized, spontaneously breathing with a closed chest, anesthetized, paralyzed, artificial ventilation on a closed chest, anesthetized, spontaneously breathing with an open chest, and finally anesthetized, paralyzed, artificially ventilating with an open chest. And later on is when you're not going to ventilate the non-dependent lung. So we'll break it up and look at what is happening at each of these scenarios. So lateral decubitus position, if you just change the position of the lungs from the erect position to the supine position, and then from the supine position, if you put the lungs one on top of each other, this is how the west zones will look like. You will have less of areas in the non-dependent lung, which is in zone 1. Most of the non-dependent lung will be in zone 2, and in zone 3 will be the dependent area of the dependent lung. And this is, I think we went through this, how blood flow would change. So in the lateral decubitus position, awake, closed, what happens to perfusion? This is non-anesthetized. Just if you turn yourself on your bed and make it light or left lateral decubitus, what? The vertical hydrostatic gradient is lower in the lateral decubitus position than in the upright position. But it does happen, we realize this, blood flow in the dependent lung is significantly higher than in the non-dependent lung. So just as it would happen with the changes in dependency. So if you put it, if the right lung is non-dependent, it receives 45% of the cardiac output, whereas if it was supine or erect, it would have received 55%. So there is a change in 10%. Same thing, if the left lung becomes non-dependent, it receives 35% of the cardiac output. In the erect or the supine position, it would have received 45%. So there is a change in 10% either way, whether it is right or left. Lateral decubitus, awake, closed. That was about perfusion. What happens to in the ventilation? This is what you will try and what you will realize, that this is in the upright position. You see where the part of the pressure volume curve and the dependent and the non-dependent areas of the lung. This is in the upright position. And this is what is happening in the lateral decubitus position. The non-dependent lung is coming into this upper part or the flatter part, and the dependent lung is in the this steeper part of the mid part of the pressure volume curve. So lateral decubitus awake, what is happening with ventilation? Ventilation is increased in the dependent lung. And why it is increasing, one of the mechanisms how it does is the dome of the lower diaphragm is pushed higher into the chest. So it assumes a more sharply curved appearance. So that is, if you look at it as from the cardiac analogy, it has a higher preload or a higher ability to contract more efficiently, as long as, very importantly, the person is awake and spontaneously breathing and you have not played with the tonicity of the diaphragm. So there is a more efficient matching of the ventilation and perfusion in the lateral decubitus position because of this phenomena. But importantly, as long as they are spontaneously breathing and not anesthetized. This is essentially the same as it would be in the supine or in the erect posture. So decubitus position without anesthesia, without paralysis, nothing is changing between the relationship with ventilation and perfusion from the dependent to the non-dependent area. What if I now give some anesthesia and patient is spontaneously breathing with a closed chest? Remember the first thing we said, moment you give anesthesia, it decreases the FRC. By decreasing the FRC in both the dependent and the non-dependent, what it happens from the awake state, both the non-dependent and the dependent, they go down a step lower in the pressure volume curve. The non-dependent goes to a more favorable, steeper part. The dependent also goes down and goes towards the lower part of the pressure volume curve. So spontaneously breathing, anesthetized, I have not given a paralytic agent, but just an anesthetic agent. The perfusion will remain the same as in the awake state. There is no change in the perfusion. The dependent lung is relatively higher perfused than the non-dependent lung. There is a fall in FRC, as we said, and each lung moves to a lower portion of the pressure volume curve. The dependent lung goes to a lower and the flatter part, as you can see here, where the non-dependent lung goes to a lower part, but in the steeper part of this pressure volume curve, so a more favorable area. So what it essentially therefore does, that the lower lung becomes less favorable as far as ventilation is concerned, because it is going towards this flat, non-compliant, regionally non-compliant area, whereas the upper lung goes to a more favorable and the steeper part of this pressure volume curve, or the more compliant part of the pressure volume curve. So that is, this bit is with anesthetized, spontaneously breathing, closed chest, no paralytic agents given. What happens if I give a paralytic agent and I start artificially ventilating in this lateral decubitus position? You'll find that this is in the awake state and this is in the anesthetized state. In the artificial ventilation, I have given a paralytic agent. What it immediately takes away is the beneficial effect that you were seeing with the diaphragmatic contraction. The diaphragmatic contraction was making ventilation in the dependent lung a lot better. So this part is going away. You lose the tonicity of the thoracic cage. The mediastinum now starts to rest on the lower lung and impedes the expansion and lowers the functional residual capacity of the lower lung or the dependent lung more. And because of the lack of tone in the abdomen, there is a more cephalad movement of the abdominal content, which is greatest in the dependent lung, and impedes the FRC or the expansion of the dependent lung even more. So this is what is happening moment you paralyzed and you are starting positive pressure ventilation or artificial ventilation. So this is what was happening with the onset of paralysis. The diaphragmatic contraction, the beneficial part of the contraction is going away. The mediastinum is resting on the lower lung, and there is a more cephalid portion is of the abdominal content is pushing and impeding the dependent lung even more. So to summarize, what happens whether they are artificially breathing, ventilated, or spontaneously breathing in a closed chest under anesthesia, the non-dependent lung is well ventilated but poorly perfused, and the dependent lung is well perfused and becomes poorly ventilated, more so if it is after giving a paralytic agent. Okay, so this is about still the chest is closed. So this essentially brings down to the maldistribution of the ventilation and this inequality with perfusion when this is happening in the lateral decubitus position under an anesthetic, more so if it is with a paralytic agent. What now happens if you are opening up the chest? Now, if you have opened up the chest, this non-dependent lung is therefore no more in the confines of the thoracic cage. And so the compliance suddenly increases. So, and what happens therefore to the dependent lung? Let us see what is happening. So anesthesia, open chest, there is no alteration in the pulmonary blood flow. The pulmonary blood flow will not change. It's essentially, again, you have to look at what is happening to perfusion and ventilation. Perfusion, there is no change. The upper lung, as I said, is no longer confined by the chest wall. It is relatively free to expand. It is over-ventilated but under-perfused. The dependent lung continues to be over-perfused but poorly ventilated. Now, that was if it was spontaneously breathing. You will not face that scenario. This is a scenario that you are going to face in practical life. Anesthetized, paralyzed, artificially ventilated into the open chest. So you would have, as we said, the mediastinum pushing downwards, the cephalid movement of the abdomen, and you can add to this is the suboptimal positioning effects. What does this lead to? Again, with perfusion, there is no alteration. The diaphragm becomes passive. We had discussed this. And the greatest ventilation is where the perfusion is the least, that is in the non-dependent lung, again, because the compliance suddenly increases, and the least ventilation is where the perfusion is the greatest, that is in the dependent portion of the lung. So to summarize what is happening, whether in spontaneous or paralyzed, with an artificial ventilation in an open chest in the lateral decubitus position, this is what the blood flow is gravity dependent. It does not change with or without anesthesia. The non-dependent lung is well ventilated, has a higher compliance because it's outside the chest wall confinement. The dependent lung becomes more poorly ventilated because it gets more compressed by the mediastinum and the abdomen, as well as the suboptimal positioning and the loss of volume of the lung because of the more decrease in FRC. These are more theoretical considerations about, but I think this is, let us finish this. So this is in a nutshell what is happening when you have one lung ventilation. Okay. And these are more theoretical. Anesthesia on an open chest, spontaneously breathing, you can have two phenomena. One is mediastinal shift and paroxysmal respiration. You are unlikely to see it because you are unlikely to see a person breathing with an open chest under an anesthetic spontaneously breathing. More likely that you see is during rib injuries where you can have mediastinal shift. Why does it happen? Because the non-dependent hemithorax, the atmospheric pressure is greater than the negative intrapleural pressure in the dependent hemithorax, which is pushing down the lungs. This is what it was happening if you look at it. And the lower diaphragm has a more efficient contraction. Remember, they're not paralyzed. The diaphragmatic tone is there. It creates a more negative intrapleural pressure. It sucks in more of the mediastinum, and therefore there is a mediastinal shift. And this can cause a circulatory change. You can also have a paradoxical respiration. During inspiration, air from the atmosphere enters the pleural cavity. So during inspiration, that non-dependent lung actually deflates and becomes small, and the lung collapses. During expiration, The collapsed lung will open up because from the dependent area the air goes up and it inflates. So during expiration, you'll find the non-dependent lung expanding. But these are, I think, more theoretical than anything else. So finally, if you come down to the tenets of one lung ventilation, and wherein you have the non-dependent lung which is not being ventilated. Now this is the real crux of the one lung anesthesia. So what do you have? Say this is the non-dependent lung. We have isolated, you're not ventilating this. What is happening to perfusion? Perfusion remains the same. The perfusion will be higher in the dependent lung purely due to hydrostatic forces. What will now happen is, what is the changes that are happening to ventilation? What are the changes that are happening to perfusion? And is there a change, the relationship between the change in perfusion and the change in ventilation? Moment you have the non-dependent lung which is not being ventilated, so you have all the blood that is going to this non-dependent lung which is not being ventilated. This becomes a part of the shunt flow. So this will be in addition to the shunt that is already there in the dependent lung. Remember, it was being well perfused but not getting ventilated, so it is also creating a shunt. So one lung ventilation will obviously have an additional obligatory right to left shunt. And therefore, one lung ventilation leads to a larger alveolar to arterial oxygen tension difference with other factors remaining constant. It will give you a lower arterial oxygen pressure for a given FiO2 when the other factors like inflation, lung inflation, how close it is towards total lung capacity, everything taken into consideration because of this obligatory right to left shunt, because there is still flow in the non-dependent lung, but there is no ventilation to that non-dependent lung. How much does this affect PCO2? I think we remember we talked about the changes in the PCO2 that was happening uh, uh, because of the linear part of the curve. uh, it has a less effect. The linear shock of and this is, I think, reiteration of what we had already discussed. The linear shock of the carbon dioxide dissociation curve ensures that the blood flowing through the well alveolated ventilator releases adequate amount of carbon dioxide. And because of the sigmoid shape of the oxygen dissociation curve, it is not able to take up enough of oxygen, and ultimately leads to this. Because of this unevenness of the perfusion, ventilation and perfusion, you have a smaller carbon dioxide gradient from the alveoli to the artery, but a much elevated oxygen gradient from the alveoli to the artery. So let us now come to the more interesting clinics after the physiology. So problem solving in one lung anesthesia. So let us go. What are the problems you solve? You solve the problems of the pre-anesthetic assessment, how you prepare, how you conduct one lung ventilation, and finally, how do you manage the troubleshooting of one lung anesthesia? So let us take it through a particular case scenario. We'll talk about a 67-year-old man who had a 50 pack year smoking history with a background of COPD, presented with hemoptysis. The diagnosis was small cell lung cancer of the right and middle and lower lobes, no significant other comorbidities, and the plan was the mother of all thoracic surgeries, the right pneumonectomy. This is how the lesion looked like on the chest x-ray, the right middle and lower lobe. As this was wet close to the carina, the plan was a right pneumonectomy. What we do in assessment is look at the history and examination, then look at the respiratory function, look at the mechanical bed spirometry, the pulmonary parenchymal function, the cardiopulmonary interaction, the regional lung functions, and then the combination of tests. And of course, you look at concomitant medical conditions. especially in this case, the preoperative therapy of COPD, whether it can be improved with any pre-medications or physiotherapy, if you have an initial preoperative assessment and a final preoperative assessment. So this was what our case was. So coming to the first question, what kind of pulmonary evaluation is needed or is indicated? If you look at it, the basis of to test or evaluate is all about what is the role and how much it is about oxygen. Is there enough that is getting into the alveoli, which is why you are checking the mechanical functions or the lung volumes, etc., etc. Does it diffuse into the lung, into the blood from the lung, which is what you are trying to look at for the lung parenchymal assessment? And from the pulmonary vessels, can it reach the peripheral tissues, what is what you are looking at, the heart-lung interaction. So the basis of test is about these three phenomena, that is about the oxygen carriage. Okay, the mechanical function you look at through spirometry, the FEV1, the FVC, the minute ventilation, maximum ventilation, the residual volume, and the TLC. And wherein you look at is the percentage of the predicted, how much is we should have done when it is corrected for age and sex and height. And ultimately, what is very, very important is the predicted post-operative. And we will come to that as we go through the discussion on this topic. So the predicted post-operative is nothing but what is the preoperative whatever function you are looking at. And let us look at the FEV1 percentage. It is preoperative into 1 minus the functional lung that is going to be removed divided by 100. How do you figure out how much of the functional lung is to be removed? Is if you know just how much of the lobes and segments are there in the right and the left. Right has, as you all know, 22 lobes, where the left has 20. So if you're thinking about functioning right lower lobe that is to be removed, if the preoperative FEV1 was 70%, what will be the predicted postoperative FEV1 in this case? You know that 12 of this will be removed, so 12 divided by 49, which is 20.9% of the reserve, and so 70 into 100 minus 29 divided by 100, which will come to 50. So you know your preoperative FEV1 is 70%, so your predicted postoperative FEV1 for this surgery, which is right lower lobectomy, will be 50. And why this has bearing, you will find out a little later. So that was about the mechanical function. The parenchymal function, the ideal test is DLCO, and many of the pulmonary function labs will give you this, but if you are not able to give you, then the surrogate markers are looking at the ABGs, looking at PO2 and PCO2, which gives you a surrogate idea about the gas exchange. And the heart-lung interaction, the classic is from this cardiopulmonary exercise testing, looking at VO2 max and the anaerobic threshold. Very few centers will have it. So what are the surrogate ways of looking at it? Is looking at the 6-minute shuttle walk or the shuffle walk test or the stair climbing test. So this looks at the heart-lung interaction. The VO2 max, the estimated VO2 max, and how do you calculate it, is height in centimeter by minus the age in years. This is, I think, they're in standard text, which we did not accept. So for a 50-year mole, the VO2 max is calculated to be as something like a figure of 34.3. So this is, again, you will get it from the CPET lab or the CPEX lab. So from these mechanical functions, from the parenchymal functions and the heart-lung interaction, there are certain numbers we need to remember when you are taking up these patients for a thoracic surgery. So what are these kind of numbers which are, when you say that if it is greater than this or if it is less than this, we will be bothered, but I will be not bothered if it is on the other side. So you're looking at FEV1 of less than 40%, which is not good. Predicted postoperative DLCO, similarly, if it is less than 40%, it is not good. If the VO2 max is less than 15 milliliter per kg per minute, it is not good. Neither is an anaerobic threshold of less than 11 ml per kg per minute, which is not good. Similarly, if you can't get these two last two values, if you have a room air PCO2, which the PCO2 is greater than 60, it is not a good sign. And if a PO2 in the room air, if it is less than 45 millimeter of mercury, it is not a good sign. So from based upon your evaluation, this kind of influence that whether a person can tolerate a pneumonectomy or can tolerate a particular lobectomy based upon the predicted postoperative, and you might therefore have to decide to know this guy cannot possibly tolerate such an extensive surgery. We might have to tone down the surgery or think of other methods. Along with this, if you know the regional lung functions, then it helps you to be more accurate, because you might say that part of the lung which is going away is anyway not taking part in active lung function. So it was not taking part. So if it goes away, it will not influence, and therefore you can reduce the calculations and get to a better number in the predicted postoperative, whatever, whether it is FEV1 or DLCO, and then come to a conclusion. And this regional lung function test can be done with the help of radionuclide ventilation perfusion scanning or quantitative CT scanning. And this is again theoretical. I have no clue as to how this is done. This brings us to the much, I think, asked question in practicals or in theory as to what is this three-legged stool of pre-thoracotomy respiratory assessment. It is essentially looking at, as we were talking about, mechanics, reserve, and the parenchymal function. These are the three legs. And what you're trying to look at is FEV1 of which is the predicted postoperative greater than 40%, you'll be happy. A cardiopulmonary reserve with a VO2 max of greater than 15 ml per kg per minute. If you can't get it, at least a stair climb test, which is where you can climb 2 flights of stair, or a 6-minute shuffle walk test. The person can go through that and without a fall in SpO2 of more than 4%, and so it should be less than 4%, that there should not be a fall in SpO2. And in the lung parenchymal function, the predicted postoperative DLCO should be 40% or more. If you can't get through, you should at least ensure that and I think this is an error. The PCO2 should not be greater than 60, and the PO2 should not be less than 45. So let's get back to our patient. This was a 67-year-old COPD coming in for a right pneumonectomy with the small cell cancer in the right, middle, and lower lobes. Say I give you certain values. Now, the FEV1 that you got from spirometry was 65%. You had a DLCO, which was 70%. And you were able to do a ventilation perfusion scan, and the right left showed a 40/60 for both ventilation and perfusion. You did because you did not have a CPEX lab. The person was able to not only climb 2 flights of stairs, he could climb 4 flights of stairs without stopping, essentially saying that the reserve is good. So will the patient therefore tolerate the procedure? Right pneumonectomy will take away 22 segments. The percentage of respiratory reserve which will be lost is 52%. But since we know it was 40/60, so there is possibly a little less. We can say that it may be around 40 to 45%. So the predicted values, we knew FEV1 was 65%. The predicted postoperative FEV1 comes to, if you do that calculation, will come to 35, and the DLCO will come to around 40. So what would be your verdict? Remember, we said the tip off is around 40. So FEV1 predicted postoperative is coming to less than 40, but the DLCO is just at 40. So you're okay with it. So what would be your verdict in this scenario? You would say, yes, there is an increased risk. Is there a survival benefit? You said yes, because that's possibly the best therapy that you can give this. And why? Because the age is less than 70. No comorbidity and the person has a good functional status. He says that he is able to climb. He could show in the climbing test that he could climb 4 flights of stairs. So, which is why you possibly say, yes, you might possibly go up and take this person up for the mother of all surgeries, the right pneumonectomy. Are there any strategies that can improve the patient outcomes? These are the some things which has proven to be beneficial. One is definitely cessation of smoking. The other is pre and post operative chest physiotherapy, incentive spirometry being the one that has shown to be of great benefit, but there is a way to do it. Things like thoracic epidural analgesia may not be in the preparation, but has shown to be of benefit in the perioperative period. And this is one type of surgery where restrictive fluid therapies have been proven to be beneficial. And there are 3 groups of drugs which have shown to be of benefit in the perioperative outcome, and these are calcium channel blockers and beta blockers, and this is mainly by diminishing the incidence of perioperative arrhythmias. And perioperative arrhythmias are one of the things which kind of relate to very adverse outcome in the postoperative period. And statins, this is not exactly know why it happens, but there are certain very nicely done studies which have shown that statins are beneficial. So what is our plan? The plan is one lung ventilation. So if once you take him into the OR, how would you isolate the lung? The most common way of isolating the lung is with the help of the double lumen tubes. And the others are single lumen endobronchial tubes and bronchial blockers, which are becoming more and more popular. So these are the single lumen endobronchial tubes. You can see it is just looks like an endotracheal tube, except that they are much longer and the cuff is much shorter and stubbier, hardly used. These are the bronchial blockers. These are the classic ones, the Cohen, Fuji, and the Arndt. Cohen possibly was one that many people initially used to use. Fuji is becoming more and more popular because of the ease of insertion. And aren't in good hands. This is possibly the most definitive ways of placing it. I think these are how you place it, what are the advantage benefits. You can easily look up text to find it out. This is again something which is coming up. This is the EZ blocker, and essentially you put it in. This sits on the tip at the carina, and depending upon which side you isolate, you will have the pilot balloon cuffs over here inflated, and that those bronchus will get blocked. Preparation of a double lumen tube, there is the conundrum of size. The traditional teaching is based upon height, gender, and personal. इसमें 34 जाएगा, उसमें 32 35 जाएगा, this में 32, and etc. etc. And the classic example has been that if it is in a female with these heights, the ones that can be used are 35, 37, 39. In Indian context, I think you have to also take into account its size 32. In males, the similar thing about 37, 39, 41. In the Indian context, I think 37 and 39 also comes in hugely and 35 hugely for males. The more better way of looking at is looking at the tracheal diameter measured at the level of the clavicles on the PA view of the chest X-ray, and the bronchial diameter if you're looking at the CT scan within 1 to 2 centimeters of the carina. And based upon this, this is a nomogram which you'll find in all standard texts about what is the measured tracheal width and what is the measured bronchial diameter and which size of double lumen tube that you want to use. And this is all given for the left side because why is it about the left side? It is because the left siders are more commonly used because of the simple reason of the increased margin of safety. And why is this increased margin of safety? Is because of the variable takeoff of the right upper lobe. And I think this is standard anatomy. This is the right upper lobe which is taking off very quickly, and it can vary from here to here, and which is why the margin of safety is much low on the right side, and the margin of safety is much higher on the left side. This is again standard anatomy. left mainstem bronchus is 4.4 to 4.9 centimeter, where the right mainstem bronchus is less than 2.3 centimeters. And the margin of safety for the left-sided is 16 to 19 millimeters. For the right-sided tubes, the margin of safety is only 1 to 4 millimeters. For a malincrot, it is slightly higher because of the way that the cuff is done. And if you want to go into further details as to how the margin of safety is calculated, you find that this is the length where from the carina to where one of the bronchus is taking off, and the length of the tube from where the cuff, the proximal end of the cuff to the distal tip, and the difference between this is the margin of safety. So you can see this is how this margin of safety is calculated, and this is on the left side. So if you're going on the right side, you'll find that this margin of safety is so less, and it is becomes a real difficulty in placing a right-sided double lumen tube. So the right-sided, and it's only with the rush tube that it can have a greater margin of safety, but placing it is only possible in very expert hand under good fiber optic guidance. So the only reason you would possibly put in a right double lumen tube is when you have left endobronchial tumors. This is again a question which can be asked at any point of time, or a penetrating or blunt trauma to the left mainstem bronchus. Obviously, you can't put in there, or a prior left mainstem reconstruction, kinking of the left bronchus after a left upper lobectomy. So very few reasons why you will be forced to put in a right double lumen tube. Otherwise, the left double lumen tube is what you're doing. The insertion of a left double lumen tube, please look at YouTube videos, and then you figure out whether the left double lumen tube is in proper position. You can do it with the help of auscultation, fiber optic, which is the gold standard. Then you have things like the cuff or the water seal test, and also fluoroscopy. Auscultation is again which you clamp the bronchial tube, only ventilate through the tracheal lumen, and you find that whether the opposite side is only getting ventilated and the side that is blocked is not getting ventilated, and vice versa. Fiber optic is the gold standard. You introduce the fiber optic. You can people have described it in both ways, whether you go in through the bronchial lumen first, or you go into the tracheal lumen and then try to see the carina, and then try to see which side you can see the cuff, and then decide how far in it is, and whether the right bronchus is kind of blocked or not. If you want to actually look at how to look at figure out this, I think after this particular session is over, please go and look up at Pete Slinger's website, thoracicanesthesia.com, and they look, it's a free site. Please go and enjoy yourself, and then look at the bronchoscopic images and try to figure out and that helps you to figure out how you understand, one, the bronchial anatomy, how you understand the correct placement of a double lumen tube, and how you can change the position of the double lumen tube or the position of a bronchial blocker if you have used this, by just knowing the anatomy of, and the visual anatomy rather, or the visual fibroscopic anatomy of the bronchial tree. So these are some images that I picked up from there. Water cuff seal test, I think again, there will be some videos in the YouTube which you can see. Fluoroscopy easily done because you'll be able to see the blue line, and if it is going towards the bronchus. But the proof of the pudding is in the eating, is ultimately when the lung is open and you kind of isolate the lung and you figure out whether that part of the lung is getting deflated or not. How do you ventilate during one lung anesthesia? Remember, you have two-edged swords. One, you don't want hypoxemia, but at the same time, you do not want to have a therapeutic or you inducing acute lung injury. Acute lung injury can happen both because of the collapsed lung and systemic reasons which you have no control on, but this is where you have control on oxygen toxicity, uh, whether you're changing the PVR to a great extent or you're doing volutrauma, atelectotrauma, or paratrauma. These are in standard texts. What are the risk factors? Which patients are more prone to have acute lung injury after one lung ventilation? And it is more about procedures, but also about the patient. So, what would be your ventilatory strategies? How much tidal volume would you use? I think this is standard protective, and you go up to 6 ml, max up to 8 ml per kg. Only if there is severe hypoxemia or severe hypercapnia, you could consider going up to 10 ml per kg. More than that, the adverse effects are more. Should we give PEEP? Uh, Protective, restrictive, or normal, it is advisable that you give PEEP to the dependent lung or the ventilated lung. And in cases of obstructive, to minimize the extrinsic PEEP, you can think of lowering down the PEEP that you are delivering. So if you have an ability to look at the pressure volume loop, and if you can have the ability to look at the inflection point, then you may use PEEP to that extent. What should be your respiratory rate? Again, the classic example is the same. The respiratory rate is 10 to 12. Uh, and this is a little counterintuitive, that what happens if there is severe hypercapnia? Do I increase the respiratory rate or decrease the respiratory rate? Pete Slinger and Benumov would tell you that it is wiser to decrease the respiratory rate. You give more time to expiration, and you give more time to the carbon dioxide to come out, and that might be beneficial. What should be the IE ratio? You can keep it at the normal 1 is to 2. In obstructive, you can increase the expiratory time, as we were discussing, to 1 is to 3 or to 1 is to 4. What FiO2 should you use? Routinely use an FiO2 of zero point 0.5. You can, some people think that during the initiation of one lung ventilation, you can go up to 60 or 80, but most people would not follow. Most literature would not tell you to do that. It is only when you're forced with a severe hypoxemia and other measures are not working that you go up to 100% FiO2. What are your target peak and plateau pressures? Your plateau pressure targeted to less than 25 centimeter of water. Your peak pressure targeted to less than 35 to 40 centimeters of water. What happens when this is an inevitability, that is atelectasis during anesthesia? How do you recruit and how do you re-expand? You know that the atelectasis will happen because of an extrinsic compression, and we talked about all those things, the depression of the mediastinum to the dependent lung, the cephalad movement of the abdominal contents, the decrease in FRC, distal gas absorption. There has also been talk about the loss or redistribution of surfactants. So how do you recruit? Before we come to, I think this slide talks about de-recruitment, which causes more of atelectasis. Is that if you use more of higher FiO2, you possibly would lead to more of atelectasis. If you do not use PEEP, you will have more of the dependent lung, which is getting atelectatic. And we talked about this, the extrinsic compression. The recruitment is with the help of the airway recruitment maneuver. And how is this ARM done? It is essentially you try to ventilate with a pressure control mode, and you give increasing pressure breaths over a 4-minute period, and you go up. You said the peak pressure should not be above 25 or 30. You go up to a peak pressure of 40 in this scenario, and you can get up to a PEEP level of 20 centimeter. Most people will not do it. They will only go up by the PIP and keep the PEEP to around 12. This is what most of us would do. And this is how the pictures looks like. So you progressively go up on the PIP up to 40. You can also progressively go up on the PEEP. Maybe you stop over here with the PEEP and let it go here. And then at the point where you found that the PIP, which was possibly the best, maybe 25 or 30, you might stay there. Once you come down again, you don't come down suddenly, but you come down in even decrements of 5 and stay at a PEEP of say 10, and that's how you would recruit most of the lungs. So it has shown a benefit in increasing the arterial blood gases. Re-expansion should be gradual, and this is classically at the end of surgery. Do not give those sigh breaths or the huge tidal volume breaths, because re-expansion may be harmful, not only to the suture lines but also to the alveolar capillary membrane and cause more edema. And it should be gradually done. The re-expansion should be very, very gradual. Do I allow the PCO2 to go up? Though the PCO2, we discussed it in the physiology, kind of stays more towards normal, but you can allow permissive hypercapnia as long as it is not changing the hemodynamics or not changing the pH to go down below 7.2. You can allow a PCO2 to climb up to even 70. What we would do is possibly stay at around 50, 55, as long as there is not much of hemodynamic alteration. What ventilatory modes do you use? Should we use pressure control? Should we use volume control? Should you use volume control with a decreasing inspiratory flow pattern? Or should you use a pressure control ventilation with a volume guarantee? If you scan literature, you'll find that none of them has been proven to be definitely beneficial. It is very, very, very individually driven or institutionally driven. What we like doing is pressure control ventilation with a volume guarantee. So if you have a problem, what do you do with troubleshooting? Say 5 minutes after the start of unilateral ventilation or one lung ventilation, you find that the oxygen saturation is slowly decreasing to 89%. The end-tidal carbon dioxide concentration is also increasing. It is increasing the plateau pressures, but the respiratory rate, changing the respiratory rate is not successful in relieving the hypercapnia. What will you do? So approach to hypoxemia, which is mild, which is defined as between 90 to 94 or 95%. You first is look at what you are doing. Is the lung well isolated? So confirm the position of the lung isolation device. First, think of recruiting the ventilated lung, as we talked about by the ARM. Most of it is because of a diminished cardiac output, which is why the peripheral perfusion is going out. So if needed fluids, inotropes, or whatever it is after you have done these corrections, then think about going up on the FiO2. Even if this does not correct, then the next step is giving CPAP to the operative lung after you have recruited, after you have asked them to the surgeons to stop operating. Optimizing the PEEP to the non-operative lung at times helps. So if you're on 6 or 8, or you might think of going up to 10. And if you have an ability to look at the loops, it is easy if you can look at the inflection point. Cardiac output, one of the things that plays a role is the type of anesthetics you are using. You might consider reduction in the amount of anesthetics that you're using. The other thing that can be changed is correcting the oxygen carriage, which is by correcting the hemoglobin, which is nothing but PRBC transfusion. This is the way that we would give CPAP to the operating lung, and this is a very, very simple PEEP device. For severe hypoxemia, which is less than 90%, how many people say it is less than 86%, is that stop the surgery, resume 2-lung ventilation. Even with this, if it is not possible, you can ask the surgeon to clamp the pulmonary artery. So you're trying to decrease the shunt at least. And things like inhaled nitric oxide or perfusion of amlodipine or phenylephrine has been theoretically and in some studies shown to be beneficial. We have no practical knowledge of this. And the ultimate is, of course, going into CPB or an extracorporeal support. I think that is what we have in today about the practical aspects of one lung ventilation.
Can you explain the mechanism of mediastinal shift and paradoxical respiration?
Okay, so you have in what is happening is this is a Very, very theoretical consideration. If you look at this, is some in the left lateral in the lateral decubitus position, you have a open chest. So what is happening? Non-dependent hemithorax is open, right? So if the non-dependent hemithorax is open, so what is happening to that pressure in the hemithorax? It is atmospheric pressure. Now during inspiration, what is happening is the dependent area that has a negative intrapleural pressure. Okay, so that is pulling in, and that is causing the mediastinum to go down, as well as the atmospheric pressure which is pushing the mediastinum to go down. So this is causing the mediastinal shift during inspiration. And this mediastinal shift or the traction to the great vessels can lead to a circulatory disturbance. And what is happening, what is about paradoxical respiration? Because of the same thing. During inspiration, because of the atmospheric pressure outside that open hemithorax of the non-dependent lung, the atmospheric pressure is pushing on the lung. So during inspiration, the lung, instead of inflating, is getting deflated. But what is happening during expiration? If you look at the dependent hemithorax, then the negative interpolation pressure because of the recoil of the thoracic cavity is getting down. So that is pushing the air in the dependent lung to go out. Now, where does it go out? It goes out into the trachea, but it also goes out into the non-dependent lung. So, so that is how it is getting inflated during expiration. The non-dependent hemithorax lung. So that is, I think it is hardly going to happen, because I don't think you will ever have somebody with an open chest, but with an anesthetized. Can happen in an awake patient, especially if you have lung rib injuries, isn't it? That's why you see the paradoxical movement of that area of the thorax during breathing.
Hello, sir. Sir, I
Yes.
have a doubt. In the west zone of the lungs, in the diagram, there are two tubes on the side, on the right and left. So once I was asked in the exam, like, what is the implication of the like pressure in those two tubes in the west zone of the lungs?
Oh, that is just uh, it is the two tubes is nothing but to show the hydrostatic pressures. Okay, so and the effect of the gravity on the hydrostatic pressures. So it is just like
Oh,
what the analogy is. It is nothing but a water manometer.